Okay, everybody, welcome to today's acid-base session. I thought today I would give you a little quiz just to see what you've learned over the last year. And if you could unmute, and we'll just go through these and see how you do. So this is a 58-year-old male who was vomiting, and you can see the patient's dysnatremic. There's hypokalemia. The total CO2 is elevated. There's a little bit of volume depletion, most likely, and pre-renal failure. And the pH is 7.49, the PCO2 is 47, and the calculated bicarbonate is 35. So the question is, what is the acid-base diagnosis? Does anyone want to take a stab at it? Nothing fancy here. It's pretty straightforward. Nobody wants to? Should I call names? Christian, do you want to take a stab at it?
Sorry, I'm just getting off my car. Just give me a few minutes and I'll do another.
Anybody else?
Metabolic alkalosis.
Correct. And remember, when you have a metabolic alkalosis, you have to also say if it's compensated or not, just like in metabolic acidosis. Remember, if it's compensated, then you do not have a respiratory acid-base disorder in addition. So that when you say that, you're actually telling another person that the ventilation is normal. Remember, if the compensation is not what it should be, by definition, you also have a respiratory acid-base disorder. If it's the PCO2 is above what you expect, it's a respiratory acidosis. If it's below what you expect, it's a respiratory alkalosis. So the question then is, when you say, is it compensated, what you're asking is the PCO2 what you would expect for the increase in bicarbonate in the context of a metabolic alkalosis. And in metabolic acidosis, you're asking, did the PCO2 go down what you expect for the decrement in bicarbonate? So in metabolic alkalosis, the bicarbonate goes up, and the acid-base rule is that the PCO2 should go up by 7/10 of that. So if the bicarbonate went up by 10, the PCO2 is expected to go up by 7. And if it's close to that, then you call that appropriately compensated metabolic alkalosis. The problem is with metabolic alkalosis, most nephrologists and clinicians don't even think that there is a compensation. So it's pretty hard to add that to your repertoire. But if you could do that, you'll be making more accurate acid-base diagnoses. Don't ignore the compensation in metabolic alkalosis like 95% of nephrologists do. Remember that it's a compensation also. So very good. This is a metabolic alkalosis, and the PCO2 is up 7/10 of what the bicarbonate went up. So this would be appropriate compensation. Okay, what about this case? Here we have a 28-year-old male who had diarrhea and NG suction. Right away, when you see that, even without the chemistries, you're thinking, well, maybe there's some acid-base abnormality. But you look at the numbers and they're normal. The pH is 7.4. The PCO2 is 40, the bicarbonate's 24. There's no anion gap, but there is dysnatremia and hypokalemia, and again, likely volume depletion and pre-renal failure. Whether it's due to diarrhea or NG suction, we can't say, but we do have normal numbers here, and we have really no clues. The anion gap is normal here. We don't have anything other than the hypokalemia and the dysnatremia that may or may not be and the pre-renal failure, which may or may not be associated with acid-base abnormalities, but here they're normal. Well, on an exam, one of the questions might be, is this normal, or do you have a combined acid-base, a mixed acid-base disorder? It couldn't be a simple acid-base disorder because you couldn't have these numbers with any of the simple acid-base disorders. But when you have normal numbers, the concept is it does not rule out multiple acid-base disorders that just happen quantitatively to be opposite in direction, but equal in magnitude. So remember, normal numbers do not rule out a whole bunch of processes. You could have 8 acid-base disorders alkalotic and acidotic, and they just happen to sum up on each of those opposite side of being equal in magnitude, and you end up with normal numbers. So that would be the case on an exam like this. If you write normal acid-base status or no acid-base disorders, you're probably going to be wrong, because they wouldn't have put diarrhea and NG suction in such a case. So can you come up then with two acid-base disorders that would be equal in magnitude by definition, since we have normal numbers, but the concept is that they must be opposite as far as their directional effects on the bicarbonate that would allow you to have normal acid-base numbers. Could anybody think of anything?
It's probably metabolic acidosis with metabolic alkalosis.
Yes, that's correct. So the answer you would put on the exam is metabolic acidosis and metabolic alkalosis. They would probably also have on back to what we were saying. On an exam, they wouldn't make it as hard as this probably, because you really have to think out of the box to say both. You really have no clues here. Typically, they would give you a patient with an anion gap metabolic acidosis and vomiting or NG suction, and the only clue would be the anion gap elevation. Here, you don't even have that. You really only have the clinical causes, and so that was correct. To be more precise, you would say, and they would probably give you that choice. If they didn't, you would say what was said. There's a metabolic acidosis and metabolic alkalosis. Likely, they would give you a non-GAP metabolic acidosis with the metabolic alkalosis. So the teaching point here is normal acid-base numbers do not rule out a whole slew of acid-base disturbances. All you know before analyzing it is that they must be opposite in direction and equal in magnitude. And you can't tell, is there 2, 4, 5, or 6? You could have 3 types of disorders causing the bicarbonate to drop and 2 causing it to go up. All you know is that the net effect is normality. You're always looking in a certain sense at net effects. So there's a dynamic situation going on all the time. If one of them became more than the other, if the NG suction was increased, the bicarbonate would start creeping up. It still doesn't mean you only have a metabolic alkalosis. It just means it exceeds quantitatively the effect of the diarrhea to lower it. Okay, so here's another patient, a 60-year-old male. No change in the sodium, no change in the potassium. The total CO2 is significantly elevated. It's 36, pH 732. The PCO2 is 72. The bicarbonate is increased, the calculated bicarbonate. Typically, it would be 1 or 2 millimolar less, but the numbers, the total CO2 or the one of the blood gas electrodes may not have been perfectly measuring things, or maybe arterial venous differences. It would not be typical to see in the same type of blood the bicarbonate exactly equaling the total CO2, because remember, the bicarbonate is less than the total CO2, which also includes the dissolved carbon dioxide. And here the PCO2 is 72. So the contribution from the PCO2 to the total CO2 is about twice what it normally would be. That you can calculate it by taking 0.03 times the 72 here, and that would typically be 0.03 times 40. So this is about a little less than double what it would normally be. So if the total CO2 is 36, you'd expect this to be about 34. The PO2 is 50, and the A gradient, when calculated, is what you see here. So what acid-base disorder is compatible with these numbers? And on an exam, they wouldn't ask you to come up with a disorder. Most likely, they'll on the boards, they'll give you a set of choices, and you have to pick the right one. But it helps if you can know ahead of time without having to choose what it is. Does anyone want to take a stab at this? Again, it's one of the simple acid-base disorders. It's not a mixed disorder here. So the bicarbonate went up roughly 11 or 12, and the PCO2 has gone up roughly by 32.
This is a chronic respiratory alkalosis.
Acidosis, right? Because the PCO2 has gone up. Yeah. So that's correct. So this is a chronic as opposed to acute disorder. And basically, you just have to remember that for every 10 increase in the PCO2 chronically, by chronically we mean 3, 4, 5 days. It takes that long to reach a new steady state. The bicarbonate goes up by 3.5. So the PCO2 has gone up 3 times that. So the bicarbonate would go up 3 times 3.5. That's how you would figure it out. Okay, let's switching gears now. Can anyone tell me what channel in the kidney is mutated in Little syndrome? Anyone know the name of the channel? Okay.
Is it ENaC?
Yeah, very good. So it's the ENaC channel. ENaC is a crazy term. The E stands for epithelial, the Na is sodium. C stands for channel. So it's ENaC. That's correct. And the channel I'll show in a minute, but the mutations are gain of function mutations, not loss of function. So remember that amiloride binds to this channel. That's how it works clinically. Miloride would be a loss of function or analogous to loss of function mutations. These are gain of function. The channel is working more than it typically would, but it's not because each channel is working harder. It's because you have more of these channels in the cell. Okay, so the mutation itself does not lead to enhanced function. It's just there's many more channels in the apical membrane of the cell than there normally are, and their total function is increased, but the unit function of each channel is not different than normal. They may ask you that actually. So what is the phenotype in these patients? First of all, is it an adult or pediatric disorder? And what does the blood chemistry look like in these patients? Well, before the blood chemistry, what's the clinical phenotype? Nothing fancy here. Well, they're usually, it's congenital. Or does anyone want to answer before I go on? Sorry, I see someone unmuted.
I was just gonna say that it's probably likely a pediatric etiology with
Very
Yeah.
good. We typically get these patients with a history, not de novo patients. Correct. This is these are usually seen in pediatrics. They have it from birth. And anything in their clinical phenotype, vital signs?
I would probably elevated blood pressure,
Yeah.
be slightly tachycardic, but I think it's probably more in terms of hypertension.
Yeah, they're hypertensive because again, they have a gain of function mutation. So they're since birth absorbing more sodium through ENaC into the blood, and that's associated with increased blood pressure. Correct. And clinically, they have a chloride-resistant metabolic alkalosis, and they're hypokalemic. So that's what you're going to see on their blood chemistries. And just to refresh your memory, I've shown this before, but this is what the channel looks like. It's called a channel, but it's actually made up of 3 different proteins. And there's an alpha, beta, and gamma. And these are not called different proteins. They're just called subunits. They all are made by different genes. They combine in the cell and are assembled like a little nanomachine. And sodium is transported through this down its electrochemical gradient into the cell. And amiloride binds to the outside. I'm not showing where it binds. That's known. So amiloride blocks the sodium transport. Now, the unitary transport of each channel is no different than normal. It's just you have a lot more of these in Little syndrome. And it's because the mutations, which tend to be in these PY motifs, decrease the degradation of these subunits. So they're produced and they're degraded like any other protein, right? There's always a turnover, but the degradation rate is significantly decreased. And so they just last longer, but they're still being produced. So the apical membrane of the cell, by apical, I mean that the urine is over here where these loops are sticking out. The inside of the cell is here where it says cytosol. There's just a lot more of these in the membrane to take sodium from the urine side here into the cell. Now, we're not talking about how it gets out of the cell. That's a separate story. And again, remember, the cell that we're talking about is the principal cell. in the connecting tubule and cortical collecting duct. And the cell model is that sodium goes through these two parallel lines, just a cartoon of ENaC. And the voltage on this apical membrane here is very dependent on how much sodium comes in. It's normally, let's say, minus 10 millivolts. The voltage is important because it's what determines how much potassium gets out of the cell, because it opposes the potassium leaving. It doesn't favor potassium leaving. Potassium in the cell is about 100 millimolar, and in the lumen is, I don't know, 5 or 10 millimolar. So there's a chemical gradient for potassium to leave, but it's opposed by this gradient. Now, there's still enough for potassium to leave on the wrong K potassium channel. But if this voltage changes, it will affect how much potassium leaves. And the voltage is dependent on how much sodium gets through ENaC. So what happens in Little syndrome is that there's a lot more sodium coming in because there's a lot more ENaC channels on the membrane. And therefore, the membrane potential is what's called depolarized. It's much less negative than before inside and much less positive outside. You can look at it either way. You're really saying the same thing. Because of this, it's easier for the potassium now to leave. You haven't changed the chemical gradient. The potassium is still the same in and outside the cell across the membrane, but you've lessened the voltage barrier the potassium has to surmount to get out. And that's why Little syndrome patients are hypokalemic. And the converse is true on amiloride. On amiloride, you block the sodium from coming in, and this voltage goes from what it was before, from minus 10, it might go to minus 20 or minus 30, and it makes it much, much harder for potassium to get out. So amiloride has no direct effect on the wrong K potassium channel. It's all through this indirect effect of affecting the membrane voltage. That's what sort of couples these two different transport processes that occur via very different proteins. So again, when you depolarize the cell and take it from minus 10, or the apical membrane, not the whole cell, but you take it from minus 10 to minus 2 as an example, which is called depolarization, you enhance potassium efflux out of the cell by diminishing the electrical barrier for potassium to leave. And conversely, when you add amiloride and hyperpolarize the cell, you decrease potassium efflux because you just make the electrical gradient much more counter to what potassium needs to easily leave. Okay, let's change topics again. In metabolic alkalosis, what is the main mechanism for the dependence on chloride? Why do we divide it up like chloride dependence and not sodium or potassium? Why is it that giving chloride itself has some magical effect of making the metabolic alkalosis go away? Anyone want to expand on that? Okay, well,
Don't-
sorry, go ahead.
Oh, sorry. I was just kind of taking a guess just because chloride of anion. So specifically, I'm assuming that if it is reabsorbed, technically the membrane potential will get more negative, in which case it should technically kind of counteract that metabolic alkalosis.
Okay, that's a thought people had years ago until more was discovered in the last 15, 20 years. But that would be a good thought if the transport of chloride was electrically mediated. And it's now known to occur, but via an electroneutral process. And it affects a specific transporter in the membrane of the collecting tubule. Actually, two different segments called the connecting tubule and the cortical collecting duct. So we'll zero in on how chloride mediates its effect now. So remember, these are the two segments that we're talking about. What does the transporter milieu look like in this segment? Well, there's a very important protein called pendrin, which is mutated in a thyroid disorder called Pendred syndrome. This protein can transport iodide, but in the connecting tubule and the cortical collecting duct, in a cell called the type B intercalated cell, it actually is an anion exchanger. So it's an electroneutral process, and it exchanges chloride for bicarbonate. and it's responsible for actually secreting chloride into our urine. So we always have chloride being secreted into the urine. It's not just absorbed. We have a different cell for that called the type A intercalated cell, but the type B intercalated cell in these segments is a bicarbonate secretor. And what happens is you need to have a certain amount of chloride in the urine outside these cells in order for it to work. When you are chloride depleted, such as vomiting or NG suction, you lower the luminal chloride concentration such that this thing stops working. And you can't secrete bicarbonate normally. But when you give chloride intravenously or orally, you now allow the chloride in the lumen to go back to what it was before. The chloride concentration has to get through the glomerulus, get through all the tubule segments before. But the bottom line is you're raising the chloride concentration such that pendrin can now work again and bicarbonate can now be secreted into the urine and dumped. And that's why when you give chloride, you are causing the bicarbonate in the blood to go back to normality because you allow pendrin to secrete bicarbonate into the lumen. So the answer is that chloride is very unique and specific in correcting the metabolic alkalosis, because when you have the generation of the metabolic alkalosis by vomiting or NG suction, whatever it is, you're lowering the chloride in the lumen outside the beta intercalated cells in the connecting tubule and the cortical collecting duct, and you shut pendrin off. So you lose your ability to secrete bicarbonate into the urine. And when you put chloride back into the system, you allow pendrin to work again. So it's not the blood chloride that you're correcting when you treat a patient with chloride. You're allowing the luminal chloride concentration to get back to its original level, and this now works again. So that's why chloride works in the chloride-sensitive metabolic alkaloses. Okay, here's another question. In ketoacidosis, the anion gap is only a reflection of the rate of ketone production. Is this true or false? We see this all the time, how patients are kept in the ICU based on their blood anion gap, which residents feel reflects the severity of the ketoacidosis or the severity of the production of the ketone bodies. Is this a true thought, or is there some additional factor that you have to think of that also reflects the level of the or determines the level of the anion gap? Is the magnitude of the anion gap only due to the production rate of ketones? Or
False. It's false. It's also like the rate of getting rid of them too.
Yes, very good. And that's something you're going to have to evangelize the residents and the medical students, not to equate the level of the anion gap, and not just in ketoacidosis, really with a lot of different organic acidoses. You have to think of how much you're getting excreted, because as shown in this cartoon here, you don't just have a proton coming in with an organic anion. The proton, remember, is the cause of the metabolic acidosis. The anion is not causing the metabolic acidosis, but it's reflected by the change in the anion gap. Remember, though, you don't have a closed system here unless you're in ESRD, right? If you have a normal kidney function, those anions are going to come out. And so the rate at which they come out will also determine the concentration of the anion gap. So what has been shown, especially in ketoacidosis, is the excretion rate of the organic anions, beta hydroxybutyrate and acetoacetate, are inversely related to the GFR. And the worsening the GFR, or if you want to say CKD or AKI, you're going to have a lowering of the excretion rate and an increase in the anion gap for the same input. So the worst patients are going to be patients with ESRD who get ketoacidosis. Their anion gap is going to go up a lot for the same input, and you're going to be really fooled in thinking they have rip-roaring ketoacidosis. Whereas if the same input occurred in you with a normal GFR, the anion gap may have only gone up a little bit. So you always have to think of what their GFR is. And you could theoretically have a patient with an outstanding GFR who's volume replete, who never had an osmotic diuresis, who's euvolemic, who has hardly any change in the anion gap at all. And yet they have, a pretty hefty ketoacidosis occurring, and the clue is that the organic anions are in the urine. So don't just look at the blood to assess the magnitude of the ketoacidosis. Look at the urine. The urine, if it's 4+, I mean, unfortunately, we can't quantitate it in millimoles per day. It would be nice to be able to do that if you could get an exact concentration of the organic anions. Then you could actually multiplying the concentration by the 24-hour urine, or even getting a ratio to the creatinine, you could actually much more quantitatively, know exactly what the production rate is. We only have this sort of indirect way of doing it by 1 + 2 + 3 + 4 +. But the concept is that if you have a 4+ ketones in the urine and your blood anion gap is normal, and you think the patient's got ketoacidosis, but everyone's saying to you, how can they have a non-gap metabolic acidosis? You have to tell them that the organic anions are being excreted. That's why the anion gap has hardly changed. Okay, changing topics again. A patient with ESRD and chronic bronchitis can have blood chemistry compatible with chronic respiratory acidosis. True or false? Can a patient with ESRD ever have a chronic respiratory acid-base disorder? At least by blood chemistry. Yeah, the answer is false. So when you have ESRD, you can never have a chronic respiratory acidosis or alkalosis. And the reason is it requires a kidney, a functioning kidney. So here's just a thought experiment where the bicarbonate's changing further as the PCO2 elevation is going longer and longer for a given period of time. We're not changing the PCO2. We had a step change in it, but we kept it elevated at a certain level. And what you see here, though, is a temporal change in the bicarbonate. It goes up first a little bit. That, remember, is just due to the bicarbonate buffer reaction, does not require an organ. We call that acute respiratory acidosis. The mirror image of this would go down. That we would call that respiratory alkalosis, acute and chronic. But the point is that this continual increase from time 0 after that just initial buffer reaction that occurred is all dependent on the kidney. You cannot have this curve without a functioning kidney. So in ESRD, it's always going to look only a little bit elevated, like it would be in acute respiratory acidosis. It won't change no matter how long you wait, because you don't have the kidney machinery to either generate this additional bicarbonate or reclaim it. So you can be fooled in thinking it wasn't chronic temporarily just because the blood chemistry always looks acute, and they could give you that on an exam. So remember that patients who have no kidney function cannot generate the changes that occur after the acute respiratory changes, either alkalotic or acidotic. It always looks acute, even though temporarily they've had it for a long time. Now, the complexity occurs in that in between, if you have AKI or you have CKD, you're not going to get the normal curve, and you're not going to quite get the so-called curve where nothing happens like ESRD. It'll be in between, and you'll be fooled into thinking there's some mixed acid-base disorder present. There isn't. It's just that the kidney, depending on its parenchymal state histologically and all the tissue abnormalities affecting the metabolic and transport processes that are doing this. Won't get into all that detail today, but you can have curves in between, and it makes it quite complicated. So remember that this curve only occurs if you have a normal functioning kidney. Okay, here's another question. In acute respiratory alkalosis and acidosis, the blood bicarbonate concentration changes predictably. The change is known, so that in respiratory acidosis, for every 10 increase acutely, the bicarbonate goes up by 1. And in acute respiratory alkalosis, for every 10 fall in the PCO2, the bicarb falls by 2. And the question is, what is the mechanism, and does it require a kidney? Another way of putting this is, sort of analogous to the other slides. If you have CKD, AKI, or ESRD, is it going to change what you predict would occur in the acute respiratory acidosis or the acute respiratory acid-based disorders? Or will it be the same independent of the state of your kidney? Okay, so the answer here is that the acute respiratory acid-based disorders are independent of any organ, not just the kidney. It doesn't matter what your renal function is. And it's analogous to what occurs just specifically with regards to acute respiratory alkalosis. It's like opening a bottle of Coca-Cola. You just drive the bicarbonate buffer reaction in your blood to, from right to left in this particular case, because the PCO2 dropped. So everything is just going to be driven from right to left, and the bicarbonate, as you can see, is going to fall. But it has nothing to do with an organ. So remember that acute respiratory acidosis and alkalosis do not require a kidney, or for that matter, any other organ. So it doesn't matter whether you have a normal GFR or don't, or whether you have tubular transport abnormalities like RTA or other things. They may independently affect your acid-base status. I'm not referring to the metabolic acidosis that can occur in ESRD or CKD. That's a separate story. I'm referring specifically to the question of, is the expected bicarbonate in acute respiratory acid-based disorders dependent on the kidney or any other organ? And the answer is no. You're just simply driving this buffer reaction like you would in any solution that contains bicarbonate. If the PCO2 went up because the ventilation or the ventilator, let's say, suddenly changed acutely, you would drive the reaction to the right. The bicarbonate will go up a little bit. But again, if someone had ESRD, AKI, or CKD, the change would be exactly the same as normal. So the answer is that in chronic, like the other slides, in chronic respiratory acid-based disorders, you do require a kidney to get that chronic change, but the acute acid-based disorders do not require a kidney. Okay, here's a totally separate concept. We have a 31-year-old female who was nauseous. She was found to have pancreatitis with hyperlipidemia, and she was diabetic, and here are her numbers. The sodium is significantly decreased, K maybe a little bit, and the total CO2 came back less than 5. Lactate was about, so they thought, okay, this patient has a severe metabolic acidosis. Lactate was hardly different than normal, no ketones in the blood or urine. But when they did the blood gas, the bicarbonate came back at 20. So as an astute renal fellow, you should be asking a number of questions. The first question should be, how could you have 20 for the bicarbonate, calculated bicarbonate on the blood gas, and the total CO2 on the metabolic panel is less than 5? Remember, they should only differ by about 1.5. With a PCO2 of 37, this is going to contribute 0.03 times 37, which is about 1.1, 1.2 millimoles per liter. Adding that to the bicarbonate of 20, this should be 21 and a half, not less than 5. So that should be the first thing that your mind notices. Now, you're stuck, because the question then is, which of these two should you be using to assess the acid-base disorder? If you use 20, you're going to go down one route. If you have less than 5, well, it's going to take you somewhere else. Now, the other thing is, if you put the 5 in here and calculate the numbers, remember, these numbers have a relationship with each other. They always have to satisfy the Henderson equation, or if you want to use logs, the Henderson-Hasselbalch equation. If you put 5 in here for bicarbonate, you're not going to get the equation working. The hydrogen ion concentration, if you convert this to hydrogen ion concentration, that's 50, 51. Well, 51 must equal 24 times 37 over the calculated bicarbonate, and that's going to come out to 20. It's not going to come out to 5. So there's something really weird going on here. Even if you take in male-female differences, if you take in venous arterial differences, if you take in cardiac output abnormality changes where these can be discrepant, you're not going to end up with a difference of 15, and this is less than 5. The assay can't even give you the true reading, so it might even be 1 or 2 here. So there's something very funny going on. The triglyceride levels with the pancreatitis were very high. The cholesterol was high, and the VLDLs were very high. Does anyone want to come up with a thought as to, first, what is the acid-base disorder? And again, when you're asked that question, you should be immediately asking whoever is addressing that question to you, well, what do you want me to use? Do you want me to use the bicarbonate? I'll end up with one acid-base disorder analysis. If I use total CO2 of 5, I'll end up with another. And when you do the math, if you use the total CO2, you would say the patient has, and we won't go through the steps, but I just wanted to show you sort of the logic of the thinking. You would say the patient has an anti-GAP metabolic acidosis and a respiratory acidosis. You would end up with the same concept if you look at the bicarbonate of 20, except both would be much milder. When you run the numbers, you would end up with the same mixed disorder. It just the total CO2 would be of greater magnitude. So does anyone want to come up with the answer as to why the total CO2 in this particular patient is so discrepant from the bicarbonate, and which one is the true value that you should believe? They both can't be right. Anyone have any thoughts on this? This could definitely be on your boards. Okay, well, it's been known for a number of years that there's one clinical situation where the total CO2 cannot be measured correctly. And the paper came out it's been known for a number of years, but a number of people have showed it since then. This is the first article where it appeared, and it's called pseudo or factitious hypobicarbontemia. It's not a good term because the bicarbonate, it turns out, is actually the correct number. It should be called hypototal CO2emia. Unfortunately, they didn't use that term, but it's due to the elevated triglycerides. Talk about that in a minute. But the concept is that light scattering due to chylomicrons or VLDL particles significantly interferes with the total CO2 measurement. So the concept here is that if you have hyperlipidemia and specifically elevated triglycerides, you can get, or VLDLs, chylomicrons, you get an abnormal reading for the total CO2. So the question then is, how's the total CO2 typically measured? So to measure the total CO2, you should know how it's done in the lab. It's not an electrode. Remember, your blood gas machine doesn't have an electrode for bicarbonate. It calculates the bicarbonate from the Henderson equation based on the calculated or the measured PCO2 and pH. There's an electrode for each of those. And the machine knows the Henderson-Hasselbalch equation calculates it. But the total CO2 is a measurement. And the method, first of all, relies on carbon dioxide being liberated. So what the machine does is it adds acid to the blood, turns all the bicarbonate into carbon dioxide, and then the bicarbonate diffuses across a membrane into another solution where there's bicarbonate and carbonate, and there's an indicator dye that gives the result. So it's really a colorimetric reaction based on how much CO2 is liberated. And the problem is that the colorimetry reaction can be affected by the amount of VLDLs or chylomicrons in there. They interfere with it. And if this is what you think might be going on, you need to use LipoClear, which gets rid of the lipemic serum before you do the assay, or you have to ultracentrifuge the blood and get rid of the VLDLs and chylomicrons. The sodium and chloride can also be artifactually decreased. So in any patient with a triglyceride of over 1,000 or a lipemic index of over 3, you should tell the lab to please do this. If they don't have the LipoClear, they should ultracentrifuge. They really won't know initially what you're talking about, but you have to be aware of it. And you might want to do it ahead of time because it can really be confusing for people. People start giving bicarbonates when the total bicarbonate IV when the total CO2 comes back. Before they get a venous gas, they think there's a rip-roaring metabolic acidosis occurring, and there isn't any. It can be very, very mild or not there at all. The bicarb could be 24. They could have completely normal acid-base numbers, and you're going to get a total CO2 of 15 or 10 or whatever it is, and think your patient has a metabolic acidosis, and there could be a lot of inappropriate therapy going on, and all it is the total CO2 is being measured incorrectly, and it's always on the low side. Okay, so remember that definitely could be on your exam. Hyperlipidemic patients who have high triglyceride levels who get total CO2s that are erroneous. Okay, here's another question for you. In a chloride-resistant metabolic alkalosis, the urine chloride can be low, true, or false. We always think of it as not low, but can it be low? Anyone want to take a stab at it? Okay, the answer is it can be low. And so let's say you have someone with Bartter syndrome. The urine chloride comes back 100 milliequivalents per day, or the urine chloride concentration comes back, let's say at 40, 50, whatever it is. But could it be 20? Could it be 10? And the answer is yes. There's two scenarios. One, the patient could have been put on a very low salt intake for whatever reason. So if their dietary chloride is low, the urine chloride excretion rate and concentration will be low. They're in balance like you and I are. The other scenario is they were put on a high water intake, or they could have psychogenic polydipsia, or they could just be wanting to drink 8 or 9 or 10, liters of water a day, or even 4 or 5. If let's say they're excreting a liter a day, and their chloride concentration is 60, if they decide to drink 2 liters a day, their chloride concentration is going to be 30, right? So the chloride concentration isn't just due to the excretion rate, it's due to the amount of water you ingest, like yours is. So you can make the chloride concentration whatever you want, depending on the intake. So remember that, because people are often fooled. You have someone with Bartter syndrome or Gittleman syndrome or Little syndrome, whatever the metabolic alkalosis chloride resistant cause is, and you get back a urine chloride of 20 or 10 or 15, and they go, oh, maybe we're mistaken. Maybe it's chloride sensitive. The answer is no. Check the water intake, check the chloride intake before you make that assessment. Okay, another question is, in a chloride-resistant metabolic alkalosis, is the chloride concentration typically above normal? Because you'll see a lot of people saying the chloride sensitive or low chloride in the urine, and the chloride resistant or high chloride. But the question is it high? Is it typically above normal, or is it just normal? And the answer is it's not high. So never use that word. It's not low versus high. It's low versus normal. The chloride concentration in their urine is whatever yours would be on the same chloride and water intake. So it's not above normality. It's just normal. So the answer is false. And can the chloride concentration be a range of values depending on the water intake? And the answer, as I was alluding to, is yes. You can dial in whatever urine chloride you want based on the water intake. Now, I don't ask that here, but the same thing occurs in a chloride sensitive or responsive metabolic alkalosis. If you have someone who's chloride responsive, the urine chloride is low, right? Remember, and you've shut off pendrin, and you can't secrete bicarbonate, and you have a low luminal urine chloride outside the connecting tubule and cortical collecting duct. If you lower the water intake, if you let's say you had someone with end-stage liver disease who was on NG suction and they had a chloride-resistant metabolic alkalosis. You measure the urine chloride and it's, let's say, 20 or 15. And now that person's put on a restricted water intake. Well, you're going to, if they were on 1,000 mils of water a day and you just made it 250 mils or 500, you're going to double the urine chloride concentration. It's going to go from 15 or 20 up to 30 to 40. And if you made the water intake a quarter of that, it's going to go up commensurately even higher. So you can be fooled the other way by thinking the chloride concentration is normal, and yet they're chloride sensitive just because their water intake is so low. So remember that in metabolic alkalosis, when you're dividing up the patients based on the chloride response, based on the urine chloride concentration, you've really always got to know what the chloride intake, or at least assess it, and what the water intake is. Otherwise, you're going to be really, really fooled in the real world, and you're going to make the wrong diagnosis. Okay, what about the fractional excretion of chloride? Let's say you decided to do that instead of measuring the urine chloride concentration only. Does that depend on water intake? True or false? And the answer is no, it does not depend on the water intake. That's why it has a higher utility than measuring the chloride concentration. In general, as a paradigm, the concentration of anything that you measure in the urine, whether it's potassium, sodium, whatever it is going to depend on the water intake. That's why it's always best to either the concentration relative to the creatinine concentration, because both are affected by water intake equally and the ratio won't change. Right? That's the same reason we get a protein to creatinine ratio or an albumin to creatinine ratio. That ratio is independent of water intake because both go up or down based on your water intake. Same is true if you're measuring an ion in the urine. If you correct it for the creatinine concentration, you have a measurement independent of water. Or if you want to measure the fractional excretion, you will also have a measurement independent of water intake, as will your 24-hour urine excretion rate be independent. So we have three ways of assessing things in the urine that are independent of water intake. The worst is the concentration of that substance alone. It's always going to reflect the water intake also. We have that substance X relative to the creatinine concentration, or you can do a fractional excretion, or you can do a 24-hour excretion. That's how you get rid of, in the clinical world, of having to think about what the patient's water intake is. Okay, changing gears again. Bartter syndrome is due to mutations in what nephron segment? The proximal tubule, the distal convoluted tubule, the thin ascending limb, the thick ascending limb, or the cortical collecting duct? Anybody? Okay, it's the thick ascending limb. And it's this portion of the nephron here. So here's, just to orient you, here's our glomerulus. We first have the proximal tubule, then the thin descending limb, thin ascending limb, and then the thin ascending limb in the medulla, outer medulla, becomes the, first of all, we don't say it here, medullary thick ascending limb, and then the cortical thick ascending limb. And this is where Bartter syndrome occurs. And it's due to the mutation of a whole slew of proteins now. It's Bartter syndrome type 1, 2, 3, 4, 5, just like RTA. You need to know the mutations in all those types of Bartter syndrome and what proteins are involved, because you'll be asked that on your boards. What about Gittleman syndrome? It's due to mutations in what nephron segment?
Distal convoluted tubule.
Yeah, very good. So it's the distal convoluted tubule. It's the second segment in the nephron that's also convoluted. It's like the proximal tubule. Those are the only two segments that have these waves. Nature probably created this so you'd have more surface area per volume. It's like an accordion. It's all bunched up into one area. The distal convoluted tubule also has that, except it's much, much shorter. That's correct. These are both segments in the cortex. So the Gittleman mutation is up here. Okay, so thiazides block the sodium chloride cotransporter, NCC. By the way, that's the transporter that's mutated in Gittleman syndrome. It's also the transporter that thiazides block. So I've given you the answer in a certain way, but anyway, this is also a process that occurs in the distal convoluted tubules. So both Gittleman syndrome and thiazide block this transporter NCC in the distal convoluted tubule. It transports one sodium and one chloride into the cell. It's electroneutral because these charges cancel. It does not see the membrane voltage. It's only driven by the sodium gradient into the cell. Cell sodium is about 20, so you have a big concentration gradient. It's not quite 140 in the lumen. It'll be less because sodium is absorbed prior to this segment, but there is still a chemical gradient for sodium. And there's a chemical gradient for chloride. Chloride inside all the cells of our body, all mammalian cells, is about 10 to 20 millimolar. It's not 100 or 105 millimolar. So the gradient for both of these things drives these ions into the cell. This NCC transporter has binding sites for each. We won't get into how it does the transport, but it's an electroneutral transporter that transports one sodium with one chloride. And thiazides just bind here. It's known where they bind. We won't get into that now. But they just stop this thing from transporting, despite the fact that the chemical gradients for each of these are still there. And this protein is mutated in Gittleman syndrome. Okay, which transporter does Lasix inhibit, or ethacrynic acid or bumetanide? They all work the same way. Is it the ENaC sodium channel? Is it the electrogenic sodium bicarbonate cotransporter that absorbs sodium and a carbonate? Is it the ROM-K potassium channel? Is it ClC-Kb, which is a chloride channel? Is it Barton, which is a protein which enhances the transport of chloride through ClC-Kb? Or does it block the sodium potassium 2 chloride cotransporter called NKCC2?
NKCC2.
Yes, correct. So it's, again, these names are historic. The N stands for sodium, K stands for potassium, and CC because the stoichiometry is known for 30 or 40 years now to transport 2 chloride ions. So here's NKCC2. This protein transports 1 sodium with 1 potassium and 2 chloride ions together. Again, it's electroneutral because we have 2 positive and 2 negative charges. It does not see the membrane voltage here on the apical membrane. It's driven solely by these gradients. Now, potassium gets transported even though it's occurring against the potassium gradient. Remember, potassium in the cell is very high. So the potassium gradient thermodynamically actually slows this thing down. It's just that the chloride and sodium gradients exceed the potassium gradient going out. So it ends up net driving K into the cell. But the point is, when you give Lasix, you block this thing. Lasix actually is known to bind to the chloride binding sites. I can't remember which one. There's 2 of them. But it blocks the transporter by inhibiting chloride binding. And ethacrynic acid and bumetanide work the same way. They all block NKCC2. And again, it's the same site in the thick ascending limb where Bartter syndrome occurs. Bartter syndrome occurs via mutations in a number of proteins. One of the proteins is NKCC2. So children or newborn infants with NKCC2 mutations, it's like they're on Lasix from birth. It can also affect the ROM-K potassium channel. The same ROM-K that we showed in the principal cell is also present on the apical membrane of the thick ascending limb. And there are patients with Bartter syndrome who have ROM-K mutations also. And there are a number of different proteins, Barton, the chloride channel, the ClC-Kb, which is on the basolateral membrane, also causes Bartter syndrome. The bottom line is anything blocking the transcellular transport in this cell can create Bartter syndrome. So it's actually a syndrome because it's not due to only mutations in one protein. But if you learn those different proteins, you'll learn also how the thick ascending limb cell functions. But Lasix is just an experiment of nature, doing the same thing as NKCC2 mutations do. Okay, let's switch gears again in the last few minutes. And the question here is, what acid causes a non-anion gap metabolic, or excuse me, this is incorrect. I think I have non-anion gap in all these titles. It should be anion gap. What acid causes an anion gap metabolic acidosis in methanol overdose? Is it formic acid, keto acids, lactic acid, or pyroglutamic acid? I mean, you learn as a medical student and resident which overdoses cause organic acidoses, but as a renal fellow, you need to know the acid itself. Just for curiosity's sake, but also so you'll know in your patients what anion is floating around.
I take a guess that it's the formic, just based on exclusion, the formic acid.
Yes. So remember that for the rest of your career, that is correct. That methanol overdose causes the production of a proton with formate. So the formate is what elevates the anion gap, and the proton, like any other organic acidoses, is always a proton coming into the blood. There's never sodium or potassium or some other cation. So you have, in this particular instance, it's formate, and it's felt that the formate itself may be what's causing the ocular abnormalities. It's not the methanol per se, and there's a number of studies showing that the formate itself can be toxic to certain cells. So yes, if you had an assay for measuring formate, and let's say your anion gap was up by 10, you would find that the formate level in the blood would be approximately 10 millimoles per liter. It's normally, extremely low in the micromole range. It's hardly measurable. So yes, the methanol is converted into formic acid. If it wasn't, you would not have you wouldn't have the elevation of your anion gap. And again, I have the same error here. This should be anion gap. So what acid is causing the anion gap in a patient who is a glue sniffer? And the answer is hippuric acid. So the toluene in the glue is converted metabolically into hippuric acid. And so the hippurate is what elevates the anion gap, and the proton causes the metabolic acidosis. So, after today, if you have time, go through every organic acidosis and not just look at the cause, but ask yourself, what's the organic anion floating around in my patient's blood? Because one day we're going to have assays for these, and you'll be measuring them. And when you're trying to do things therapeutically, you'll be following not the level just of the anion gap, but the level of the organic anion that's elevating the anion gap. So you need to know chemically what you're going to be measuring. Again, same error here. This should be what causes an anion gap metabolic acidosis in people who are taking acetaminophen for a chronic period of time at a high dose. This could be on your exam. It's sort of a favorite topic for nephrologists now.
Pure glutamic acid.
Very good. So the acetaminophen, if it's taken chronically, causes pyroglutamic acidemia. Correct. And it was actually sometimes called oxoproline in the literature. It's a bit confusing. So look for both of those things on your exam. I don't know which one they're going to show you. It's rare. The frequency is true frequency is unknown. A lot of times it's unknown because people just aren't tuned to it and aren't aware that they need to look for this. Anyone who's on Tylenol chronically and develops a metabolic acidosis, your brain must immediately think that it could be due to this. Don't start. I mean, you can think of everything that could be causing it, but this causal association you should think of immediately, because other people won't. It's not something that occurs to most nephrologists or residents or other fellows. And it's thought to be associated with long-term acetaminophen use. The majority of patients are women. It's not clear why that is. They tend to be chronically ill with other things. So whether this can occur in completely normal people is not clear. It seems to resolve temporarily with stopping the acetaminophen or other supportive measures. Some people recommend giving N-acetylcysteine. There's some anecdotal evidence that it may accelerate the recovery, but don't take this as something firm that's been studied rigorously. It hasn't been, but it's something you might want to think of to try if stopping it doesn't work right away. And some people have been dialyzed. Okay, everyone, I think I'll stop there. I'm sorry for going over, and we'll leave it at that. But I think you did quite well. Keep going over questions. Challenge your mind. Don't be happy with what you know. That's the secret with this, and obviously other things too. And these slides will be available for you if you want to review them.
Thank you.
Any questions or anything that wasn't clear? Okay. Have a great day, everybody.